Welcome everybody. I am Dr. Manar lecturer of medical parasitology. Our video today about amoebiasis. In this video, you will be able to know etiology, transmission, clinical manifestations, diagnosis, differential diagnosis, therapy, and prophylaxis of amoebiasis. Let's start with an introduction about amoebiasis. Amoebiasis or amoebic dysentery is an infectious disease caused by the intestinal protozoan parasite which is called Amoebiasis histolytica. And most infections are clinically asymptomatic, and only about 10% cause a spectrum of disease ranging from amoebic dysentery to amoebic abscess of the liver and other organs. Also, in recent decades, severe disease due to free-living forms, which is waterborne amoeba of the genera Naegleria and Acanthamoeba, which is a facultative parasite, has been observed in humans and animals with increasing frequency. And an often lethal amoebic meningoencephalitis caused by Balamuthia occurs in animals and humans, mainly in immunosuppressed patients. These free-living amoeba are optionally parasitic and found in human central nervous system, such as Naegleria fowleri, Acanthamoeba, and Balamuthia. Let's start with an etiology. The major parasite in Amoebiasis histolytica, which is a pathogenic form, is the cause of both symptomatic and asymptomatic infections. And there are 3 stages of Amoebiasis histolytica found in humans. First stage is tissue or motile vegetative form, which is called trophozoite. Its size about 20 to 30 micron and move actively by means of pseudopodia. It invades the intestinal wall and phagocytose erythrocytes, leukocytes, and tissue debris and cause acute amoebic dysentery with its complication. This picture showing Amoebiasis histolytica trophozoites with phagocytosed erythrocytes. The second stage is vegetative, which is intestinal lumen form. Its size from 10 to 20 micron. These forms live freely in the intestinal lumen and are found in chronic infection. And the last form is permanent form. Its size about 10 to 15 micron, rounded, immotile, and due to a tough cyst wall, this form is highly resistant, and cysts are the sole infectious stage. Let's talk about the developmental cycle of Amoebiasis histolytica. Number 1, cysts with 4 nuclei is ingested orally. 2, trophozoite with 4 nuclei leaves cyst within small intestine. 3, both cytoplasm and the nuclei divide to form 8 small amoebae. 4, mature trophozoites reproduce by constant binary fission in intestinal lumen. 5, uninucleate cyst, which is called pre-cyst with marginal chromatoid bodies. 6, cyst with 2 nuclei and chromatoid bodies. 7, mature cyst with 4 nuclei, which is called metacyst. And number 8, infectious cysts are set free with feces. Then 9. During acute amoebic dysentery, when it forms enlarged to large vegetative forms, which is called tissue forms. And number 10, tissue forms enter submucosa of intestinal wall. Then blood is spread to brain, lung, liver, skin, and other organs with invasive extraintestinal amoebiasis with abscess formation. After etiology, I will talk about transmission. Let's start with Entamoeba histolytica transmission. Transmission of Entamoeba occurs by oral ingestion of water and food, mainly of plant origin, contaminated with cysts. Also, flies and cockroaches play a role of mechanical transmission. And the infection of young children by their mothers excreting cysts or by manual feeding with contaminated fingers is frequent, and infections are common in homosexuals. About Naegleria, invades the organism via the olfactory mucosa by small flagellated stages with large pseudopods, for example, during swimming in stagnant fresh water. And about Acanthamoeba transmission, points of entry of Acanthamoeba are respiratory, urogenital tract, and the skin. And amoebic keratitis is mostly found in carriers of soft contact lenses, and transmission occurs due to insufficient cleaning of these lenses. And about Balamuthia mandrillaris, free cysts containing amoeboid stages are the infectious forms and hasn't been found in the environment. The transmission route is unknown. About clinical manifestations, in Entamoeba histolytica infections remain asymptomatic in 15 to 25% of cases. The incubation period of amoebic dysentery varies. After ingestion of cysts, before acute invasive dysentery starts gradually with mild gastrointestinal symptoms such as diarrhea, sometimes alternating with constipation. Severe mucoid blood diarrhea with spasm, colic, and anismus may be developed, and the patients pass from 10 to 12 stools per day. And in malignant or complicated cases, high fever, electrolyte imbalance, and cachexia occur. The course of amoebic dysentery varies between spontaneous recovery within few days or weeks to chronicity, and relapsing colitis lasts months or years. And a typical complication is an amoeboma, which is a localized tumor-like inflammatory colonic granuloma, which resembles a carcinoma. And intestinal amoebic infection may be complicated by metastasis in the liver. And about amoebic liver abscess may develop just a few weeks after a previously acquired intestinal infection, but usually occurs after a period of 2 to 5 months, and they may be solitary or multiple hepatic lesions. In 80 to 90% of cases, it is found in the right liver lobe, and it is 10 times more common in men than in women. A single liver abscess may reach the size of a fist or even a child's head, while multiple foci are smaller but rarely observed. And in most patients present with an acute or subacute onset of fever and abdominal pain, which is localized in the right upper quadrant and sometimes radiating to the right shoulder, and tenderness over the liver and hepatomegaly are common. However, the clinical diagnosis may be difficult, as about 10 to 15% of patients with fever about pleuropulmonary amoebiasis may complicate amoebic liver abscess, mostly due to abscess rupture through the diaphragm, pleural embolemia, and intrapulmonary abscess may develop, and patients have fever, dyspnea, and cough, and the mortality may reach up to 30%. Also, amoebic liver abscess may rupture into the peritoneal cavity and pericardium, so inducing peritonitis and pericarditis, both associated with high mortality. And blood spread may result in cerebral, splenic, and genitourinary amoebiasis. About cutaneous amoebiasis is the result of intestinal amoebiasis and manifests itself as painful ulcerations and condyloma-like lesions in the anal and the preanal skin regions. And about the clinical manifestation of free-living amoeba. Free-living amoeba of Naegleria, Acanthamoeba, and Balamuthia have been identified as agents causing infections of the CNS of humans and other vertebrates. They may be responsible for mild or severe disease. About Naegleria manifestations, as we know that a Naegleria species enters the olfactory mucosa and through the cribriform blade gain access to the CNS, causing primary amoebic meningoencephalitis. Its incubation time is from 1 to 9 days. Symptoms are severe and include headache, high fever, nausea, vomiting, photophobia, neck stiffness, and coma, and leading to death in 95% within 3 to 10 days after onset. About Acanthamoeba and Sabinea, invade people with chronic disease or immunodeficiency via the respiratory or urogenital tract or skin, followed by blood spread to the CNS. They cause acute or chronic granulomatous amoebic encephalitis, inflammation of inner organs, and diarrhea. Several forms of Acanthamoeba cause painful keratitis, especially in wearers of certain types of contact lenses, which can result in permanent visual impairment and even blindness. And the prognoses are generally poor. About Balamuthia, cause subacute or chronic granulomatous encephalitis in both immunocompetent and immunosuppressed patients, and also its prognosis is poor. About diagnosis, let's start with intestinal amoebiasis. Diagnosis of intestinal amoebiasis depends on 1. History and clinical signs, 2. endoscopic examination may reveal small solitary ulcers with exudative centers and edematous hyperemic cramps. The clonic mucosa is hyperemic and edematous and covered with pseudomembranes. Number 3. Microscopic detection of trophozoid and cysts. Liquid feces and samples taken by endoscopy, either from biopsy, ulcer secretion, and swab specimens, are suitable materials. Samples must be fresh and should be examined within 30 minutes after suspension in saline by phase contrast microscopy, showing trophozoids with linear movement. And samples may also be examined after fixation in alcohol and stained with iron hematoxylin stain or trichrome stain. Microscopic detection of trophozoids is pathognomonic for Amoebiasis histolytica infection. And fecal samples may also be examined after flotation and concentration techniques. For subjects with clinical signs but negative results of microscopic examination of fecal samples, the examination should be repeated at least 3 times to avoid false negative results. Therefore, we can depend on enzyme-linked immunosorbent assay, which is called ELISA, to detect parasitic antigens. But specific antibodies which can be demonstrated by ELISA may persist for many years after recovery and are of limited diagnostic value. Also, asymptomatic cyst carriers are usually serologically negative. Number 5, we can use PCR in diagnosis. About extraintestinal amoebiasis. We can diagnose extraintestinal amoebiasis by humoral antibodies against Amoeba surface antigens are found in almost all patients with extraintestinal amoebiasis. Also, we can use ultrasound, CT, and MRI. In case of rupture of an abscess, fine needle biopsy aspiration under sonographic guidance may be helpful. Now, diagnosis of primary amoebic meningoencephalitis, which is caused by Naegleria fowleri. Microscopic detection of amoebic organisms in the CSF leads to diagnosis. A wet mount of CSF is examined for the presence of motile Naegleria fowleri amoeba. Also, monoclonal antibodies and PCR can be used for doubtless identifications. About granulomatous amoebic encephalitis, Acanthamiba trophozoids are rarely seen in CSF. Culture techniques with biopsy specimens and corneal scraping use agar plates with Escherichia coli and incubation at 35 to 42 degrees for 3 weeks. And in Balamuthia, diagnosis depend mainly also in culture, but use in vitro mammalian cells, not on agar, and it can be transmitted to mice. After etiology, transmission, clinical manifestation, diagnosis. Now I will talk about differential diagnosis in case of amoebiasis. In case of intestinal amoebiasis, must be differentiated from colitis of other etiology, such as schistosomiasis, ulcerative colitis, Crohn's disease, colonic carcinoma, and plantidiasis. And in case of extraintestinal, abscess of other etiology and malignant tumors must be excluded. In case of liver and lung lesions, especially cystic echinococcosis, tuberculosis, brucellosis, and Hodgkin disease must be excluded. Let's talk about how to treat a case of amoebiasis. In case of asymptomatic intestinal carriers, we can use baronomycin 25 to 35 mg per kg 3 times a day orally for 7 days, or iodoquinol 650 mg 3 times a day orally for 20 days. And in case of amoebic dysentery and amoebic abscess, we use metronidazole 750 mg 3 times a day orally for 7 to 10 days, or use tinidazole 2 grams per day orally for 3 days. And then for elimination of intestinal cysts, also use baronomycin and iodoquinol. In case of heavy extraintestinal infection, we use also metronidazole, but give metronidazole intravenous, not oral, in a dose of 750 mg 3 times a day for 10 days, or use tinidazole 2 grams per day for 5 days intravenous. Then also for elimination of intestinal cysts, use baronomycin and or iodoquinol. In case of primary amoebic meningoencephalitis due to Naegleria fowleri, we use drug of choice is amphotericin B 1.5 mg per kg per day in 2 doses intravenous for 3 days. Then 1 mg per kg per day intravenous for 6 days. In addition, 1.5 mg per day intrathecally for 2 days, and subsequently 1 mg per day intrathecally for 8 days. In case of granulomatous amoebic encephalitis by Amoebiasis species, drug of choice is pentamidine plus sulfadiazine plus flucytosine plus fluconazole intravenous. In amoebic keratitis, we can use miltefosine. And in case of Balamucium infection, patients may be treated with pentamidine plus clarithromycin plus azithromycin plus fluconazole plus sulfadiazine plus flucytosine. And finally, about prophylaxis. Number 1, general hygienic measures include prevention of contamination of water and food by amoebic cysts. 2, use of insecticides for control of flies and cockroaches, which play a role in mechanical transmission. 3, improvement of sanitary hygiene, especially in toilets, and a change of living conditions in areas of endemicity. Four, travelers in the tropics should avoid raw food and fruits that cannot be peeled, and they should never drink unfiltered water. And 5, amoebic cysts are not destroyed by low concentrations of chlorine or iodine in drinking water, so heating to 50 degrees kill amoebic cyst in the water within 5 minutes. And chemoprophylaxis or vaccination against amoebic infection is not available. Seven, known carriers shouldn't be employed in eating establishments or water sanitation until after appropriate therapy and laboratory confirmation of cure, and proper cleaning of contact lenses minimize the risk of amoebic keratitis. Also, hydrogen peroxide based cleaning solutions are effective in this infection. Thank you.